Well, good evening, everyone. Happy Tuesday night. My name is Alexa Boylan. I'm the Chief Communication Officer here at IMPD. I want to thank you all for joining us this evening on a very, very important conversation. Before we jump into the presentation, I do want to go over just a few brief points. The first being this town hall. First of all, it relies entirely on you. So, in order for this to be successful, we want you to be engaged. We want you to ask questions. We are here to help clarify things. So if you do have a question, I ask you put it in the chat of the link to your right. I believe it's on the right corner for me. So you can go right into the chat. Also send it to everyone if you don't mind. That way at the end of the presentation, everyone can follow along. And as I mentioned, once the presentation is done, we will go through each question. That being said, I do want to let everyone know we're not going to be able to answer questions about specific cases or incidents that are ongoing. And that's because we are trying to protect the integrity of the investigation. So please understand we do that again to protect the integrity of the investigation. So keep in mind, if we can't answer the question, we're going to try to find somebody who can. With that, I think that's everything that I needed to mention. Let's go into our expectations for this evening, what we hope that you're going to get out of this presentation. So we're going to introduce MCAT and CLCR to you. We're going to explain some of the staffing hours for MCAT and why it is the way it is. We're going to give you some information about what MCAT does and does not respond to regarding calls. We're also going to give you an overview of the CLCR program. You're going to hear a little bit about the CLCR's hours, what districts they serve in, and what their staffing looks like. And then we also are going to provide you with some statistics and run loads to give you an idea of the programs. So with that, I'm going to turn it over to Major Macklemore. I believe she's with us. And I know she's feeling a little bit under the weather, but I know that she didn't want to miss this important conversation. Major?
Thank you, Alexa. Good evening, everybody. I am Major Tabitha Macklemore. I'm with our Operations Support Bureau with IMPD. With that, MCAT does fall under that, and Alexa was right. I am recovering from a surgery, so I'm off duty, not in uniform right now. But it is very important for me to be on here for this, and I do know that our clinical supervisor, Tiffany Fagan, and our sergeant with IMPD, Lance Dardine, and our CLCR supervisor, Andrea, have amazing things to say tonight. So I'm going to turn it over to Sergeant Lance Dardine right now.
Thank you, Major. As she stated, my name is Lance Dardine. I'm the sergeant over the Mobile Crisis Assistance team. So I'll go ahead and get started, and we'll talk about MCAT. Most co-response teams are unique. They are unique to their respective municipality, and they are unique to the needs of the community. However, there is a fidelity to the model, and for those purposes, this is our definition of a co-responder model. So the co-responder team model for behavioral health response is a police-based intervention that pairs trained police officers with mental health professionals to respond to incidents involving individuals experiencing behavioral health crises. If you look at teams across the nation, they may look a little bit different. They may respond a little bit differently. But for the most part, this is the fidelity to the model where you have a trained police officer with a mental health professional. Now, it's hard for a city unit like us that are spread out to get in one place at one time. So this is not our whole team, but this gives you an idea of what our team does look like. We, of course, have a few off for vacations and so forth and some trainings. But again, just wanted to kind of give you a little snapshot of what our team looks like. So now I'm going to turn it over to Tiffany Fagan. who is the clinical supervisor for MCAT on the Eskenazi side, to explain their structure.
I apologize, I was muted. Thank you, Lance. As Lance said, I am the clinical supervisor for the Mobile Crisis Assistance Team. I provide day-to-day supervision for the MCAT clinicians. So as you can see from our structure, the MCAT team has access to multiple levels of supervision through Sandra Eskenazi Mental Health Center. Even though MCAT has been around since 2017, we always are encountering new novel situations, and we use the structure to gain guidance and try to handle these crisis situations the best way possible.
On the IMPD side, of course, you can see our chiefs right there. And then the Operations Support Bureau starts with Major Tabitha McLemore, who spoke earlier. And then we have Lieutenant Steve Spears, and then myself, and then we have the MCAT detectives. In August of 2017, Dr. Brad Ray, who's a PhD researcher, did a 6-month study on runs within the East District with MCAT. This was a 24/7 response at the time. And after looking at the data over most runs were between 10 a.m. and 6 p.m. Not much was going on late at night. So it was decided to make the MCAT hours when we went citywide, Monday through Friday. And then we have 5 shifts from 7:30 in the morning to 3:30 in the afternoon. And then we have 2 shifts from 10 a.m. to 6 p.m. I've looked at other co-responder models across the nation, and their numbers seem to be about the same, about 8 o'clock in the morning to about 6 o'clock at night are most of these mental health calls. So right now, those are our hours. All 6 IMPD districts have their specific team, with the Northwest District having 2 teams. When it comes to MCAT responses, I'm going to kind of go through our roles. So MCAT primarily responds to active 911 crisis calls. An example of this would be a mother of a 23-year-old male, and she calls 911 because his behavior over the past few months has been a bit erratic. He's become paranoid. He's talking about the FBI following him, and he's quit his job, and he's putting newspapers over the windows, and he's not eating well. So if she were to call 911, our dispatchers would dispatch the first 2 district beat officers. So these are the officers that are working that specific area. And those 2 officers would get called first. And then MCAT would be what we call the 3rd car. And then we would get dispatched with those other 2 officers. That is the primary role of MCAT and our response to 911 calls. Remember that scenario because I will come back to it on the next slide. When it comes to referrals, internal and external, let's say an officer at 2 o'clock in the morning, they have been to this house numerous times and they don't have enough to take somebody to the hospital. They may actually refer that individual to MCAT, usually through a phone call, usually through an email when we're working, just to tell us about that individual and that they need help and need services. As soon as we can, we will follow up with them. And then the same scenario could be from a family member, a friend, a neighbor, someone else in the community, such as maybe somebody from a church or clergy. And I mentioned a hospitalization earlier. If a person has a mental illness, they're a danger to themselves or others or gravely disabled, and in need of hospitalization, a law enforcement officer in the state of Indiana can place them into protective custody and take them to the hospital for up to a 48-hour hold. Now, this can get a little more complicated when they get to the hospital. So let's say the doctor needs more time. They can actually petition the court for up to 14 days. But for argument purposes for tonight, the officer can do what's called an emergency detention, and that's up to a 48-hour hold. What that means is that the hospital has up to 48 hours to do an assessment on that individual. Now, let's go back to that prior scenario where the mother calls in on her son. The expectation when we go to the run would be to do an assessment. We would assess for suicidal behavior and other safety concerns. We then assessed for those 3 prongs for that emergency detention that we just covered. If we have them, then an emergency detention is more than likely going to happen. But if the individual does not meet that criteria, then we would focus on appropriate resources. Part of our job is to develop and maintain active community police partnerships and connect those individuals to those appropriate resources. We have MOUs or memorandums of understanding with many of the treatment facilities in Marion County, from Eskenazi to Adult and Child, Recovery Centers of America, the Community North Behavioral Health Pavilion, to Cummins Behavioral for Children, to Aspire. We try to find the resource that meets the individual's needs and connect them to that resource. And sometimes we have to hold their hand through the barriers that are sometimes there to connect those individuals to resources. We follow up with these individuals as much as is necessary or wanted. And this is really the key difference that I've seen when I've done my research nationwide for different co-response teams is MCAT, even though we do respond heavily to 911 calls, our follow-up is very intense, and we find that most of our successes are because of the intense follow-ups that we do. So now we can get into some of our statistics. These are the year-to-date numbers from January 1st of this year to September 30th. So we took just over 2,300 active runs. We had only 19 active run arrests, and a lot of these are warrants that sometimes we can't just ignore. And then some of these phone calls and investigations are, again, you know, we may have to talk to a lot of hospitals and treatment facilities to try to get people connected. We did just over 800 follow-ups. We had almost 400 referrals in this time. We did 351 home visits, and then we did 35 community events. If you look at our active run numbers by district, so these are the active 911 calls. So the Northwest District has the most, but they also have 2 teams on Northwest. And then I won't read every district there, but you can see those numbers and how they stack up. When it comes to the downtown district, if you are not aware, it's a small district geographically. And then a lot of our investigations and the runs that we take downtown have to do with businesses maybe having some issues. We do try to help our unhoused community members down there as well on the downtown district. When it comes to the time spent categories, I do see that there was a glitch in the matrix in the 61 to 90 category. I got there put twice, but just add those numbers up. But these are, again, active runs. And so we spent 997 of those runs, took either 0 to 30 minutes, and then 31 to 60 minutes, about a little over 800. And then you can see that the over 90 minutes actually surpasses the 61 to 90 minutes. So we had 274 runs that took over 90 minutes. And that is because when we decide to take somebody to the hospital, by the time we get the call, we get to the location where the run is, we calm the situation down, we figure out what's going on, we make the decision to take the person to the hospital, we take the person to the hospital, we get them there, we talk to the staff, we get back in our cars and finish our report. That's probably going to be about 90 minutes or so at least. So that's where the number comes from. This is our MCAT team, including myself as the sergeant and the officers. We are missing one detective who was on vacation this day, but this is the MCAT team as far as the officer side. So now I'm going to send this over to Andrea with the clinician-led community response.
Thank you, Lance. So the clinician-led community response team we call it the CLCR for short, provides in-person interventions for individual and crisis, working with both the individual and their support systems to assess, de-escalate, and connect them with appropriate services. Each team includes at least a master level clinician and a peer support specialist. We provide interventions in an environment where the individual is experiencing a crisis, so it's often in the home or in the community. Next slide, please. So the CLCR is a partnership with Stepping Stones Therapy Center and the City of Indianapolis's Office of Public Health and Safety. We respond to our neighbors having a mental health crisis, and we are dispatched solely by 911. Next slide, please. Our hours of operation are 24 hours, 7 days a week, 365 days a year. Currently, since this is a pilot program, we are only being dispatched to the downtown and east districts of Indianapolis at this time. And so our average response time is about 22 minutes, which is under the national average of 45 minutes for mobile crisis. So we are urgent response, but we're not emergency responders. We respond to suicidal ideations, psychiatric emergencies, emotional or psychological distress calls, as well as substance abuse concerns. Next slide, please. So a few of our steps. So we are a pilot program and we launched July 1st of 2023. So our stats are from January 2024 to October 28th of 2024. So far the CLCR has responded to approximately 710 calls. Our current staff model looks about like 24 people at the time, and that includes 3 program managers, which are the supervisors on duty, as well as 10 clinician and 8 peer support specialists.
All right, thank you so much. I believe we're going to go into questions at this point, and looks like we're doing great on timing. So please put your questions in the chat. While we're waiting for some of those, just want to point out some of the contacts with their emails and phone numbers from some of the people that you heard from, or some of the people that you might need to get in contact with regarding our crisis response town hall. So first question, is this presentation available online? It's not available online right now. I don't believe so, Lance, right? But we are going to record this town hall and we'll be posting it on YouTube on IMPD News's YouTube page. So it will be available. But Lance, do you have any hesitation sharing this presentation if somebody wanted it?
I would not be. No, that's fine.
Yeah, if you put your email address or if you want to just send it to me, we can make sure that you get the presentation. Next question is about, I guess this would be for you, Sergeant, to the time spent categories. Could you clarify the numbers for the range 61 to 90 minutes? We might need to go back to that slide if that would be helpful.
As I stated, I apologize. There was a glitch in the matrix, so it should be 156 plus 38. I don't know why when we calculated that, it made 2 different categories or 2 different columns.
And we could also send that to Jade if we need to. If she needs an updated numbers, we can get that to her, right? Okay, cool. Next question. Are there any language services available during these calls? I think she means specifically for this town hall. There isn't one tonight, but I do know that we've held a Spanish-speaking town hall in the past for IMPD, but unfortunately, no. That's something that we definitely should be looking into, though. That would be wonderful. Okay, and so we're getting some emails in. Some people are asking about the presentation. And again, if you're interested, if you don't want to send it to everyone, you can just send it to me and I'll make sure that following this call that we send you that presentation. And Sarge, I might just have you make some of those changes before we send it out, just to make sure that the right information is getting out there. So let me just save this. Okay. Can you explain the next question? Can you explain the involvement of EMS with MCAT and CLCR and what type of runs require EMS versus calling out MCAT or CLCR? Sergeant, do you want to start with that or?
I can definitely start, and I may grab Tiffany on the back end here. But in August of 2017, MCAT was a co-responder model with the officer, the clinician, and a paramedic. What we saw during those 6 months was the paramedic just was not used very much. So IEMS, I think responsibly so, pulled out and left the officer and the clinician. If we are on scene and we do need a medic, we can get on the radio and call for EMS. Tiffany, do you have any other thoughts on that?
I think with IEMS no longer participating in MCAT, I think also there was kind of doubling services being provided because there was a medic on the team, as well as if someone needed to be transported via ambulance, then another team was being called out of service to come and do that. So I think that's also another factor that contributed to EMS no longer being a part of MCAT. But EMS would receive medical runs. So if someone is having a medical emergency, EMS would respond. MCAT would respond if it was a mental health emergency. And now with CLCR and MCAT, if CLCR is in that district, then if there's no possibility of weapons or anyone being aggressive, then MCAT or CLCR would respond. If there are weapons involved or there's some danger, then MCAT would be dispatched.
Great, thank you both. And I apologize. I want to go back to the question that was asked previously. This was from Liz. I think I misunderstood it. So let me just go back to it. I think she's asking about language services available when either MCAT or CLCR gets called out. Sergeant, could you address that, or is Tiffany that better for you?
Sure. So just like with any other police run, if any officer on the IMPD needs an additional language, we can reach out to another officer who may speak that language, or we do have access to what's called a language line. And I've had to use that many times for somebody on that line to translate for me. So yes, it is available.
Perfect. And I do know that we have a number of people requesting the presentation. I am seeing it. So we will get that to you, if not by tonight, probably by tomorrow. Okay, let's see. What other questions? Okay, this one's coming from Corlina. She's asking, how can the community best support MCAT's efforts? Sergeant and Tiffany, do you want to take that one?
Oh, that's a good question.
Tuffy.
Yeah, that it's kind of open-ended as well, right? So I think doing stuff like this is really important and spreading the word. Actually, it was maybe last week I ran into somebody and they saw my car and they're like, "What's your car?" And I explained to them, and they said, "Oh, I didn't know Indianapolis had this." And we've been going since actually, June, August of 2016 and 2017. So just kind of spreading the word and letting people know that we have a crisis team. That if you are to call 911 and it is kind of a mental health crisis and it is during our hours, they are more than welcome to request MCAT specifically. And if we're available, then we can definitely come.
Exactly, Lance. I mean, I cannot tell you how many times I'm asked what MCAT is. A lot of the community doesn't know what MCAT is. And then, as you said, Lance, when you call 911, specifying that it is a mental health emergency will help get you the appropriate team. So just everyone being aware of those things.
Alexa, I have a quick question for them. How does 988 play into this? And do you encourage people who maybe don't want to call 911 or shouldn't call 911 to utilize 988?
Chief. So a couple of years ago, 988 was put into law. It is a national law. And then Governor Holcomb signed it in. And so it has been going on for about a year and a half or so now. And when somebody calls 988, they get, it's in Indiana, they do not get a crisis counselor. They get what's called a crisis specialist. This individual is trained to handle crisis calls, and they can talk that individual through and try to get them as much help as possible over the phone. Now, one thing the state is also doing nationally as well is they are putting together what's called mobile teams. Okay, so they are non-law enforcement teams, and they are able to respond and again get that individual possibly connected to appropriate resources and calm the situation down. And if the individual needs another level of care, the state has also given funds to what's called a CCBHC, Certified Community Behavioral Health Center, to put together what's called crisis stabilization units. This is not a forced hospitalization. This is completely voluntary. And these crisis stabilization units are 23 hours and 59 minutes. So that's as long as they're going to be able to keep you. And in that time, hopefully it's a good timeout for you, where you as the individual in crisis can go to the facility, maybe get some resources, take a break from the stress that's going on, and again, try to get connected to what's appropriate.
Thank you, sir. Next question is an interesting one. They're saying that sometimes we hear of people that are experiencing a mental health crisis ending up in jail or prison just because there's nowhere to go. How has MCAT helped reduce people ending up in jail when they were actually needing some sort of resources or help?
Tiffany, would you like me to start on that?
Lance, actually, I think you'd be better at handling that one.
Sure. Okay.
Law
So
enforcement.
I don't think it's just MCAT, but I can talk about MCAT. But I think the culture itself has seen a huge transition, okay, over the last several years. And I think officers, not only nationwide, but especially locally, with really, Chief, it's not just because you're on here, I promise, but you and the rest of the command staff have really supported us and this culture change, understanding that we cannot arrest our way out of this problem. There are different solutions, there are better solutions, and working with the community and having programs like CIT, the entire department has been trained in mental health first aid, which is an 8-hour amazing course on mental health. And so we're working constantly on changing the culture and having officers understand, look, try to dig a little bit deeper on your runs. And if it's a mental health issue, find out what's appropriate is, because sometimes arrest may be appropriate. It may be, right? But a lot of times what we're finding is we can divert away from these criminal justice programs and maybe get that person to a hospital that doesn't necessarily deserve to go to jail, because we know that some of these jails nationally are some of the biggest mental health providers in their state, the jail, and that's just not appropriate. So really, it's the change of culture, and then MCAT again with the command staff's approval, we can take our time. If I have one of my MCAT detectives and they start their shift at 7:30 in the morning and they're with a family for 6 hours, I am perfectly okay with that for one run. as long as, you know, they're trying their best to get that family connected to appropriate services. And if it takes 6 hours to do that, then it takes 6 hours to do that. A normal officer, a normal beat officer, they're taking, I mean, sometimes dozens of runs a day. Okay. My high, I think, was 28 runs in one day as a beat officer. There's no way I could have taken my time with the family and walked them through all these mental health barriers and so forth, right? So MCAT has the time, we have the permission to really peel back the layers on these runs and get somebody who is in crisis connected to what's appropriate at that time.
Also, I think something else that is beneficial is that our clinicians and the officers have the knowledge of resources that they can be linked to. You know, that we have the AIC here in Indianapolis that is a linkage hub that can be utilized as well. So just knowing what resources, and you know, not every officer is going to know those. So if MCAT can be utilized that way, and we can, instead of diverting, or you know, instead of someone going to the hospital, diverting them to a different resource, could be helpful as well.
I would also like to just throw in there real quick, the relationship that Tiffany and Lance have with the jail itself too. Just because a person is getting arrested and sent to jail doesn't mean that they're not going to get help. Lance and Tiffany reach out to them all the time over there to make sure that their mental health team is actually touching base with someone that they know that needs help in there too. Or if one of the clients that we're working with has ended up in jail, to make sure that that mental health team is making contact with them. So just because they are going to jail doesn't mean that they're not still going to get that mental health treatment and that help that they need.
Thank you
Actually,
all.
going to piggyback, sorry, one more thing on that I was thinking of was it's not just the jail staff that we have a great relationship with. The city has a great diversion program called Pear Court and Behavioral Health Court with Judge Jones. And I have their prosecutor and their public defender on speed dial, and we talk constantly. So if an individual maybe does get arrested for something, and we know that their mental health component is a large part of that, then I can get with them and they work together. So it's a prosecutor and a public defender, and they work side by side on these mental health cases with Judge Jones, and they really focus on getting this individual help and maybe you know, working with the sentence or working with the pre-diversion so they can get help and not have to have that charge on the record.
And if I could add just one last thing, as we see 988 build out across the state with the crisis stabilization centers, that there'll be more places for individuals to go for that 23-hour and 59-minute observation, and those are voluntary places.
A lot of good information there. Does anyone want to add anything else on that topic? I don't want to cut anyone off. Okay, let's keep going through the questions because I see the chat continues to get a number of them. Next question that I'm seeing is, are there any numbers or data on how many runs might require a language interpreter? I don't think that's something that we have tonight, but if she wants to follow up with the PIO's office, we could potentially look into that. Sergeant, you don't have anything like that available right now, do you?
I would say anecdotally speaking, they're on the low side, but that's not something that we track. I don't know if there's another way to track that, but we don't.
Yeah, I'm not sure. Okay, moving on.
Alexa, can I add something very quickly?
Of course.
So at the Office of Public Health and Safety, we also have this pilot program where we are training people within the Haitian community and the Burmese community to become peer recovery coaches. And so the hope is that these people, after getting trained, will be able to either serve, you know, at the AIC or with the clinician team. And so that way, if there is a, you know, a need for a different language, you know, a Creole speaking person or Burmese speaking person, we can have that representation. Obviously, it's just a pilot. We only have about 15 people from each community, I'm sorry. And so the hope is that, we'll have the representation within those teams, at least on the CLCR team, to be able to serve that community. And also we'll always encourage people to, when they're hiring, to have, bilingual individuals as well. But just to keep in mind that this is something that is, that's in the works, so.
Perfect. Thank you. Thank you. Next question goes back to, I believe, something Sarge already talked to, which was MCAT hours. I know that was on the presentation, but could you just go over that briefly?
Our hours are currently 7:30 in the morning to 3:30 in the afternoon for several teams. And then we also have teams that come in at 10 a.m. to 6 p.m. and that is Monday through Friday.
Great. Thank you, sir. Next question. Are there plans of expanding, or what would be the criteria for that? What can the public do to expand knowledge about this? So I don't know if that's in regard to MCAT or CLCR. Sergeant, let's start, I guess, with MCAT. Are there plans of expanding MCAT, or what are the limitations of that?
I am going to pass that question to either the major or somebody else on the call that is in my chain of command.
That's fair.
Hello. Did the chief chime in there or no?
Yeah,
I'm
I
hoping
did. I'll
actually
take it.
Justin,
There's,
I'm hoping
there's,
Justin can actually clarify if
yeah.
which
Hey,
program.
Alexa, I got
Yes.
it. The value in expanding MCAT only is there if you have the clinician support to go along with it. If it's just cops, then we're defeating the purpose. So there is, whether people believe it or not, there's not a ton of clinicians, especially clinicians that want to work overnight. So we're staffing it the best we can to the hours in which we see the most need. And additionally, I think we can fill some of these gaps in as some of the clinician only led responses start to take off. And as we see some of these centers popping up across the state, because we truly don't want people to go to the emergency departments in the middle of the night. Now, that may be where we have to take them, but there are a continuum of care issues. There are what kind of services do they actually get when they go to an emergency room in the middle of the night for a mental health crisis, when a lot of these places are built to deal with heart attacks and gunshot wounds. And so we don't just put people out just to say we did. Lance, I do want you to talk a little bit about just the great work that our regular officers do with people in crisis, and the number of times they successfully take people into custody for treatment at a hospital. It's in the thousands over the last couple of years, I'm assuming. And so while we have these great teams, I don't want to overlook the great work that our regular beat cops do every day with people that are at the peak of their crisis, because in order to be taken into custody, you have to be experiencing all those things that Lance or Sergeant Dardine talked about in his presentation. So Lance, you want to talk briefly about that?
Yes. So great work is probably an understatement. Working with these officers day in and day out, and even having to watch some body cam footage, even responding with them alongside them with MCAT, they do amazing work. And on average, we do between 3,500 to 4,000 emergency detentions a year as a department. MCAT is a small number of that just because we're a small team. So the majority of those individuals we're taking into protective custody to the hospital by a regular, normal, everyday beat officer. And you don't really see that on the news, right? They're taking into custody, usually without incident. They're taken to get help, usually without incident, about 4,000 times a year. So I definitely echo what the chief said. We have a way internally of recognizing our officers, and I try as much as I can to do that when I see a normal beat officer do some amazing crisis work, and they just go out and then they take the next run, and they take the next run, and they take the next run. So thank you, Chief, for bringing that up, because it definitely is an important point.
Thank you both. Next question. Can community partners request a callback from MCAT after and CLCR after 911 dispatches. How is this request being monitored? So a callback?
So
Sorry.
if somebody calls 911, let's say that officers or CLCR respond and they want us to let them know kind of what happened. Is that what I'm kind of gathering, or just maybe some follow-up questions on what happened? Is that kind of what I'm getting from the question?
I think that's where they're asking. I'm not exactly sure though. Yeah.
I think we
Love
do
to
that
call
on
back.
somewhat of a regular basis. We work with a lot of our, the businesses that may call. Again, we get a lot of churches and clergy groups that call. People walk into churches and maybe he's having some issues. We actually do some training for them as well. But yeah, if anybody wants a call back, they just have to reach out. They can. All of our officers have business cards, and we hand those out. We have MCAT brochures that we hand out. And they give their office lines out freely, and then they can always contact me, and I can look that up and figure out what is going on. No problem.
It's also important, though, to remember that we do want to respect everyone's privacy. So that information is protected. So sometimes we can't disclose some of that information to just anyone.
Sense. Tiffany, while I have you here, you might be the next person for this question. What certifications do the clinicians with MCAT who ride with the officers hold? And then the clinicians and peers with CLCR. So Tiffany, do we want to start with you first about the certifications for MCAT? Sometimes I think people confuse them. Let's start with MCAT first, and then we'll go to Andrea.
Sure. So all of our clinicians are fully licensed clinicians. So they hold an LMHC, LCSW. We do have licensed marriage family therapists that work on our team, and all of our clinicians have years of experience working with crisis.
Wonderful. And now let's go to CLCR. Andrea, do you mind talking about the clinicians in that program?
Yeah, so our team is a little different. So we have our supervisor who is clinically licensed. So that is your LCSWs and LCMHs. The licensed clinical is the supervisor. And then our clinicians are master level license eligible clinicians who are responding to the calls. And our peers are in the process of being certified peer specialists. If they have not already obtained that.
Thank you. Next question, and I think she might mean CLCR on this. Because Sergeant, can you clarify, is MCAT available in every police district?
Yeah, so MCAT is available in all 6 districts, with 2 teams being on Northwest. I believe maybe the question is talking about the clinician response team. So Andrea, would you like to take that one?
And let me just go over the question real fast. I wanted to make sure. So is there a timeline on when CLCR could be available across all districts? And then why did you specifically choose downtown and east for that 24-hour coverage? Can you clarify that or just give us some perspective?
Yeah, so usually expansion depends on how many calls dispatch receives and where the calls come from within the city. So we are currently working with 911 dispatch to gather data and determine what would be the best route for implementation for expansion. This was what was done for the the first expansion that we did from downtown to East District. So any expansion with the CLCR services will be typically slow and gradual as it is a pilot program.
Thank you, ma'am. Next question. This might be a little bit of a tricky one. Which program is better suited for a youth experience crisis? I think it might depend on what that crisis is, but Andrea, any thoughts on that?
I would agree. It would depend on the call. I wouldn't say that either one would be better suited for youth. without
Dr.
that.
Tiffany.
It's what's appropriate, and you know, we have relationships with a lot of the different treatment facilities. So if the individuals around the west side of Indianapolis and there's a youth, well, we have Cummins Behavioral down there, and we have contacts at Cummins. So I may reach out to my contact there, and I'll say, hey, we got a 13-year-old with a crisis. They live about 4 blocks from you. Do you have any openings? Can you get this family in today for some sort of an intake or something like that? So it really is dependent on each situation, where they live, and what contacts are maybe close and what's appropriate.
Great, thank you. Next question. How often would you say that a patient ends up having an emergency hold placed on he or she? There's a certain criteria that you talked about that needs to be met, but this person has spoken to some who are concerned if they do reach out to 911, they could be forced into the hospital. What would you say to that?
Actually, I just confirmed this number with a constituent of mine at one of the behavioral health places. I'm not going to say which one, but he said that let's say that we have brought 100 of those emergency detentions to the specific facility. He said that 50% get admitted. That's actually a good sign. That means that law enforcement is actually making the right call. Because what we didn't want to see is 2%. Okay, that would be extremely low. So this particular hospital that the IMPD officers take emergency detentions to, about 50% of the time, the individual gets admitted to the hospital.
Thank you, sir. I know we are coming towards the end of our town hall. I do want to give all the panelists an opportunity to give some closing thoughts while we are waiting on a few extra questions. If you have any questions, please put them in the chat. But Tiffany, Sergeant, Andrea, any closing thoughts about the programs, about the lives that we impact here, and the reasons why?
Well, I want to thank everybody for attending. That's awesome. We need more people knowing about MCAT and CLCR. And make sure you're telling other people about them, about the programs as well.
And I'll just jump in and say, absolutely thank everyone for attending. I think it's important work that everyone on this call is doing, whether it is the CLCR or MCAT, just because, as we know, mental health is real and it's a serious thing that's happening in our community, and all hands on deck for this, for sure.
Thank you, everyone, for coming. I want to thank everyone on the call. Tiffany, being my right-hand person through all this, thank you. We call each other multiple times a day. And then my leadership as well. Thank you for allowing us to do this work. I was a street officer for quite a few years, and it's interesting. I felt like I was doing good police work, right? But it wasn't until I took the job in June of 2016 and I started doing this mental health response that I really felt like I was doing real police work. And I haven't arrested somebody in probably 10 years. You know, it's not about that. It's about getting people help. And so I'm passionate about this, and our teams are passionate about this. They would not do it if they weren't, because it can definitely be a stressful job. But they come in and day out. They are the boots on the ground. Tiffany and I do so much administrative work. We don't get it out as much as we want to. So the teams really deserve all the credit. It literally is all about them and the work they do constantly all day long. So I'm really proud of the work that all teams out there are doing. And like the chief said, I think the officers, they get it right 99.9% of the time. And that's something that usually is overlooked. So please remember that as we go forward. And again, thank you so much for your time tonight.
We do have a few other questions, if you don't mind me just going through them, if we still have a few minutes. That's okay. Sergeant, this one might be for you. Can you discuss how MCAT teams are called out to scenes? Can a caller request one, or is that something that dispatch determines when that 911 call is made?
A little bit of both. It can actually come from a variety of different ways. So an individual can call, they can request MCAT, and if we're available, we'll definitely be dispatched. The dispatchers do go through training. Tiffany was a part of that. And so the dispatchers know that if they can pick up on some of the mental health signs and symptoms, right, they can hit a little button on their computer and it will automatically dispatch an MCAT officer as well if they're available. And then again, the internal referrals I think are really important. And one of the reasons that the training we do is so important is that officers who are responding to a run, it could be just a regular disturbance. MCAT's not called at all. They get to the scene and they realize very quickly, oh wait, this is mental health related. And they get on the radio and they say, hey, MCAT 14, can you back onto my run? We've got a mental health issue here. So like I said, we have every officer on the department has been trained in mental health first aid, and our recruits continue to be trained on that when they go through our academy. And then we have a pretty substantial CIT program, a crisis intervention team program. We do 2 to 3 classes a year, and officers can come and learn a substantial amount about mental health. So when they get on these runs, they can act accordingly, but they can also pick up on these signs and symptoms, and then they can let MCAT know.
Thank you. Few other questions. Is MCAT or CLCR available to those who are located in either Beech Grove or Lawrence police districts? Or is it just IMPD territory?
That's a really great question. We're running out of time, so I'll try to talk as fast as I can and still be understood. So municipalities across the state, across the nation have some sort of co-response teams. They are in different parts of Indiana. Our partners up in Hamilton County have multiple different types of co-response teams. Johnson County has a co-response team. Lawrence has a chaplain that kind of does this type of work, and him and I talk quite a bit if we have spitball stuff together. Beech Grove, I'm actually not sure about them, but we're starting to see how popular they are, and municipalities are saying, "Hey, wait, we need to do this," and they're putting their money where their mouth is. Carmel, in particular, just added a therapy dog not too long ago, and an extra clinician and an extra officer.
Just a few more minutes to go. I do want to remind everyone this town hall was recorded. We're going to be posting it on IMPD News's YouTube channel. I also, if you do want the presentation emailed to you, feel free to put your email address in the chat and we'll get that to you over the next few days. With that, we want to thank everybody for joining us. Any of the chiefs, any closing words from you? I want to thank everybody for taking time out this evening. Chief Bailing, any closing words?
Well, thank you all. I appreciate this great team, our partners at Eskenazi and with CLCR, and Director Bernard Rumi Tucker with OPHS, and my own team with Sergeant Jardine and Major McLemore. These are individuals who truly care about helping our community. They choose to do this work. No police officers forced to be on MCAT. They all choose and want to be there. And that's because they care and we care. And I wish there was a world where the police did not have to interact with anybody in crisis, and that just the professionals that live in that world and work in that world could be there. But that's not where we find ourselves right now. We're working toward it. And my hope is that eventually we're out of that business altogether and people are going right to where they need to get the help they need to be better. Thank you.
Sir, with that, everyone have a wonderful evening, and we'll see you again soon.